This is Ashley with TravelTrim. I'm a physical therapist and I'm interviewing a colleague and I would like to say, acquaintance of mine, Dr. Clark Holmes. Dr. Holmes is a non-op sports medicine doctor, and we're going to talk a little bit about what that means, but why don't you introduce yourself and about how you got where you are and about your practice.
Thanks, Ashley. It's great to be here. We'll just kind of make it fun, keep it easy today.
Thanks.
So, as Ashley mentioned, Dr. Clark Holmes here. Impact Sports Medicine and Orthopedics is the name of my practice.
In Nashville.
In Nashville, Tennessee. That's right. Music City. So, been here 13 years. This is the 10th year anniversary of the practice this past June. So, thanks. It's a very gratifying situation to be a practice owner. It's got its own set of challenges, but I would not change it for the world. So, it is great. So, I love the autonomy that comes with it. And my mission is really to provide full body musculoskeletal care to individuals of all ages. And so we have patients right now, 94. 94 is our oldest, and those tend to be women. Women tend to outlive the men, but we've got some gentlemen in their 90s. And then I'll see as young as 6 or 8. I don't usually treat the toddlers or the babies, but we'll get 6, 8 years old. And we treat head to toe, so head to toe. So literally head, which means brain. Okay. So the sports medicine doc will do concussion care.
Okay.
And then to the toe, literally, we'll treat toe problems. We'll treat hammer toes and fractures and bunions and things like that. So it's a very gratifying practice because I have a lot of variety in my practice. And so no 2 days are the same. Some days it's geriatric day, which I love taking care of the older individuals because they really appreciate what we do and we can change their quality of life. And some days it's athlete day. It really is. But as a sports doc, everybody thinks that you have to be an athlete to see me. And that's not true at all. So we like to think of ourselves as experts in non-operative care, meaning non-surgical care of orthopedic issues.
Okay.
And my fellowship was in sports medicine. And there's some individuals that morph into primary care doctors that dabble in sports medicine. Ever since I finished fellowship over 20 years ago, I've essentially been an orthopedic doctor. And I'd say in the last 10 years, we've developed this cool specialty that we may call interventional orthopedics.
Okay.
So you've heard of interventional radiologists, you've heard of maybe interventional cardiologists, interventional pain doctors. And so what that means is we're doing a lot of minimally invasive procedures in facilities, even surgery centers. So I still go to the operating room and do some procedures, but I do a lot of procedures right here in the office.
Okay.
And so think of me, if you know heart or cardiology, you have your cardiologist that is not doing the big bypass surgeries, they're not doing heart transplants, they're not doing valve replacements, but they're doing the stents and the angioplasties, they're putting pacemakers in, and they're interpreting the echocardiograms, they're doing ablations. And so we are more like the interventional cardiologist, where a lot of procedures, a lot of diagnostics, but we're not doing the big cuts.
Okay.
So,
So you treat head to toe, including the spine.
Right.
So anybody that's had like pain or an injury, they can come see you.
Absolutely. And so, we don't turn many people down. And so I'll just be honest with you. There are a couple things that I don't love taking care of. They're not my wheelhouse. And that are people that have had spine surgery.
Okay.
That is a very complex set of situations there. You got hardware, you've had a fusion, you've had several discs taken out. You've got long rods in your spine because you had a major scoliosis surgery. I just don't feel like that's my area of expertise. So I'm not as well equipped to take care of that. But most spine problems, and that's 99% of the other reasons people come to the doctor, I do take care of. And that's going to be, I threw my back out, which is going to be a sprain strain, SI joint problems, disc problems, arthritis, nerve pain down the legs, kids with stress fractures. So a lot of athletes with stress fractures in the spine, what we call spondylolysis or pars defects. So yes, I do care for the spine, but we come at it with a comprehensive non-surgical approach.
Okay. And I'm gonna jump ahead a few of my questions since this feels natural. When would somebody say, okay, I've hurt myself, I'm gonna go see Dr. Holmes versus an orthopedic surgeon? Like, how would a patient differentiate?
Great. So 95% of what dons my door does not need surgery.
Okay.
And we're well equipped to be unbiased. I mean, there's not many orthopedic problems I can't initially take care of.
Right.
Now, there's going to be the 5%. Let's give you an example. You have a displaced fracture. It's going to need surgery. Well, guess what? I've got partners in the office. I got peers out in town that are experts in treating that fracture. I can refer you out. ACL surgery. It's a really good surgery if you tear your anterior cruciate ligament, one of the basic or more major stabilizers in the knee. That's going to do well with surgery, not a procedure I do. But I'm equipped to diagnose all these conditions. I'm equipped to kind of get you in the right spot. And fortunately, 95 out of 100 can stick with me.
Right. So it's a more conservative, but it's still treatment.
Absolutely.
So you can work with patients about whether or not they're getting better conservatively or they are going to need surgical intervention.
Right. Yeah. So I would say in orthopedics, the large majority of conditions, musculoskeletal pain does not need surgery. And so
I know this as a PT.
Yeah. You know that, right? You've been doing this a long time.
Right.
You get it. So we're on the same page here. And so, but we've got a large complement of things we can do.
Right.
And once again, I like the fact I can be unbiased. I don't have a dog in the hunt for you to have unnecessary surgery.
Right.
And so what's interesting in orthopedics, there's a lot of conditions that really don't need surgery and shouldn't have surgery.
What are those?
Yeah. All right, so a lot of tendon problems. You know, your classic tendonitis. Tendonitis doesn't need surgery. Non-displaced fractures don't need surgery. The majority of arthritis doesn't need surgery, right? And the majority of spinal conditions.
We're going to say that again. The majority of arthritis doesn't need surgery.
Exactly, yeah. Most spine conditions don't need surgery. And so that's a huge part of what comes to the door, is orthopedic conditions that don't need surgery. And then you got a lot of conditions that can actually go either way. And that's where it gets kind of fun, controversial. You know, let me give you an example. Meniscus tears in orthopedics. For 20 years, you've got a meniscus tear, you should have surgery. Well, we've kind of hit the pause button on that, and we said, you know, how big is this meniscus tear? How much pain are you having with it? Is it locking your knee joint? How much swelling? What has already been tried and not worked?
Right.
What could be tried and has a chance to work? What is your activity level? How old are you? Do you have pre-existing arthritis? So meniscus tear is not just a meniscus tear. And what commonly was treated with a strong surgical recommendation at this day and time probably needs a lot more careful discussion. And then you got the small percentage of things that really should have surgery. We referenced a displaced fracture, an ACL tear in a younger athlete or a very active individual that likes to cut, pivot, change directions. Although some people, if you're just a walker or hiker and you can stabilize your knee with a brace or physical therapy, you may not need ACL surgery. But most individuals, most athletes are going to opt for ACL reconstruction. It's going to provide stability to the knee. It's a good surgery. What about joint replacement? Hip replacement. Once you get severe hip arthritis, that's a great surgery.
Yes.
90-95% of patients super satisfied. Game changer. A hip surgery, particular replacement, frequently gets my endorsement. Labral tears. Labrum being that ring of cartilage helps stabilize both the hip joint and the shoulder joint. You know, that's a controversial topic too. A lot of those can go either way. Some need surgery, some don't. So I would say maybe 10-20% of what comes to see me may be in that gray zone. You know, which doesn't have to have surgery, but could have surgery. And probably only should have surgery if we've exhausted all conservative non-surgical options and we hadn't got the job done.
So what are some things that you can do non-operatively that can get patients, because me in the clinic, I'll see someone and they're having pain and we're trying to strengthen, but pain is limiting what they're able to do in terms of strengthening and stabilizing whatever joint we're working on. What can you do to help that? Right,
exactly, great point. And so traditional treatment measures, let's talk traditional first. All right? You mentioned pain, we gotta get pain down.
Yeah.
How do we get pain down? Well, some medicines usually are commonly used, and do we want to use an oral medication? Do we want to use a true prescribed medication? Do you need help on how to manage it with over-the-counter medications? Are we going to use oral, topical, okay? Injectable becomes a good option as well. So, you know, some people just need the right dosing of Advil, lead, Motrin, Tylenol. What's the right dose? What's a safe dose? What carries side effects? Let's go over those side effects. What are your other medical conditions that really you need to stay away from that medication? What do you have? Comorbidities is a term we use, where we should stay away. For example, a lot of people really have no business taking the large amounts of Advil they need to be taking. So we're going to help with that. What's a prescription medication that may be safer for you?
Right.
Topicals, for example, diclofenac, also known as Voltaren, is a popular choice. It's now over the counter, although some insurance still cover it. So that's an option for a topical. Steroid injection. Steroids get a bad rap, but there's a time and a place for a steroid. And so can we get pain and inflammation down with a very specific steroid injection around or in the location of pain or pathology, and then allow physical therapy to become more effective? So a lot of times probably what you struggle with, and you nailed it, hey, pain is limiting our ability to improve range of motion, improve flexibility, improve strength. So you and I have to partner. What you add to the equation is great. What I add to the equation hopefully can be great. But together, our patients are going to have better outcomes than if we just try to do it by ourselves.
And I know a lot of the research is saying for the shoulder specifically, and I would assume that it would be true for other joints, that if it's a more arthritic condition, that we need to steer our patients away from surgery towards more conservative measures, that the outcomes are actually better long term for not scoping the joint or clearing the joint out.
True, right. Yeah, the old clean up the joint surgery, arthroscopy still has a time and a place, but we have found the outcomes are not great with a lot of those. And people say, so-and-so doctor scraped away my arthritis.
Right.
And I'm like, well, you can't really scrape away arthritis.
Right.
Arthritis is loss of cartilage, sometimes involves bone spurs, cystic changes, inflammation in the joint, swelling. So you can't just clean up arthritis.
Right.
That's a commonly used term by doctors, but it's probably not accurate. And so you are right. You either treat non-operatively and really maximize those treatment options into the point where a joint replacement may be inevitable. But so many people are just resigned to the fact they're going to have joint replacement. We say, no, I don't think so. You're not there yet. You may never get there. And in my practice, we're doing a lot of things now to keep people from having deterioration of the joints.
Right.
Good examples of platelet-rich plasma injection.
I was going to ask about that.
So we call that PRP. It's been around in orthopedics for about 15 years. Involves drawing blood from a vein here in the arm. We spin it in a centrifuge here in the office. That rapid spinning separates the blood into really three parts. You have red cells, white cells, and the plasma. The plasma is very rich in our platelets. What do our platelets do? They help our blood to clot, but even more effectively in our practice, we're using those concentrated growth factors that are found in our platelets to inject into an area of damage. So take an arthritic knee, for example, which is the #1 way we use PRP. We're hoping to modulate inflammation, relieve pain, improve function, and slow or stop the deterioration within the joint. And so we think, based on our own studies as well as anecdotal evidence, that we are slowing the deterioration within the joint. So let's say the average person is losing 6% of cartilage per year. What if we get it down to 0, 1, or 2%?
Right.
And all of a sudden, your mild arthritis at age 40 is still mild at age 50, and you actually feel better because you've been able to exercise, keep your weight at a healthy level, unload the joint, and all of a sudden, we're not looking at a joint replacement. We're just looking to maintain, a healthy lifestyle.
Right.
So PRP is kind of a game changer in orthopedics. And although more data is needed, and we've got 40 good quality studies showing it's a nice, effective, safe option for knee arthritis, more studies are needed, but we love the results we see.
That's wonderful. Insurance doesn't pay for it yet.
It's not yet. That's a yet ... We'll see.
That's because we got to get more studies.
We do, and insurance is a whole other topic. We can
we'll talk about that later. We'll talk about that later.
That's a sticky one, but right now you're right, and we try to charge what's a reasonable amount.
Right.
What would I be willing to pay for this? And so try to be
knowing that it's helped so many people.
Right. And in long term, it may be a great investment.
Right.
If you're saving money on other medical entities that maybe are just treating symptoms.
Right.
If we're doing something that's game changing, not only treating symptoms, but preventative medicine, then it's probably a worthwhile investment.
Exactly. Maybe even prolonging or avoiding a joint replacement as well.
Yeah.
What other treatments do you have outside of, what I would do in terms of a therapist, in terms of strength and decrease inflammation?
Yeah.
What can you do for a tendonitis?
So you bring up a good point. So let's define tendonitis. So tendon connect muscle to bone, right? Itis, inflammation. So usually when something first starts hurting, unless there's a big injury, that is an inflammation in or around the tendon. So tendonitis, if we can catch it early, That's rest. Hey, what am I doing to create this? Am I walking too much, jogging, start a jogging program too fast? Am I playing, pickleball 5 days a week and my shoulder's hurting? Did I do too much yard work and now I've got elbow or shoulder problem? And so let's take away the overuse activity. Okay.
For a time.
For a time, not forever. We never like to say never to patients, but for a time. And that's where we can guide you. Do we need a week of rest? Do we need a month of rest? Do we need 2 months of rest? So we have a feel for what we think the time frame is going to be for the amount of rest. We talked about medications can treat inflammation. So we can use steroids sparingly, whether it be oral or injectable, for an itis early on, especially if we don't think there's much damage. We talked about oral medications. We talked about topical medications. So itis, physical therapy can play a nice role because there may be some biomechanical issues that led to that tendon getting inflamed. So do we have muscle imbalance? Do we have weakness? Do we have inflexibility? And someone like yourself can come in and correct that while I'm doing my thing to take pain and inflammation down. So that's tendonitis. Early treatment, better outcomes. So if something starts to hurt, should I Google and figure out how to do it, or should I see the professional?
Right.
Well, it's worthwhile to see the professional. Do you Google how to fix your car? You might, if you have a little background there. But most people, let's take it to what we perceive to be the expert.
Right.
Tendinosis, what is that? I've heard my doctor mention that. I've seen that online. Osis usually means degeneration or some damage. So if you went in and took a piece of a tendon that's been hurting for 3 months, 3 years, you look under a microscope, you don't see inflammatory cells anymore. You see disorganized fibers. You see unusual appearance. So a lot of what we see, what makes it to the office, is not just tendonitis anymore, it's tendinosis. So a lot of the same treatments can be employed, but...
So it's like a chronic tendonitis.
Chronic, exactly. Yes, and so the steroids, not as effective. Medications can treat symptoms, but not as effective at eliminating the problem. Physical therapy, probably very effective, and you could speak to this, but how you rehab an acute inflammatory tendon is different than how you may treat a chronic tendon problem.
Yes.
PRP becomes a nice option. PRP got its start in orthopedics, being studied for tennis elbow, which is a lateral tendon problem. The majority of the time it's tendinosis or it's tendon tearing.
Right.
So that's the third kind of tendon problem, tendon tearing. Tearing sounds bad. Sometimes it can be. Depends on how big is the tear, how much pain is associated with it, how much dysfunction is associated with it. You'd be surprised how many tendon tears we see that people, their pain is 1 out of 10, they still have full motion, they just hurt episodically. So we always have to say, treat the patient, not just the scan.
Right.
But tendon tears, some of those do need surgery. Let me give you an example. You fall down the stairs, you tore 3 or 4 rotator cuff tendons, the edges of the tendons are this far apart, you're 40 years old, you can't raise your arm above your head, surgery, good option. You're probably gonna have a good outcome. It's gonna take you 6 months to recover, but hey, you need to go see my orthopedic surgeon colleague who's great at fixing rotator cuff tears. You got a 20% tear, you're a tennis player, you're 45. Well, we're not talking surgery there.
Right.
Okay, we're talking appropriate rest and activity modification, a physical therapy regimen, maybe a PRP injection, changing some of your tennis biomechanics. Do we need to meet with your tennis pro and work on your serve technique? Are we playing 3 days a week and for 3 hours at a time, or maybe once a week is a better option? Should you play doubles instead of singles? You don't have to serve as much. Are we slamming too much at the net where we need to play maybe at the baseline? So there's lots of things, and that's where sports medicine comes into play.
Right.
We understand athletes.
And the sport that they play.
And the sport that they play. And I don't necessarily have to play it anymore to understand it. I've played most all these sports in my life, at least for a time. So I feel like as an athlete, I understand the sport, I understand why you're playing it. I'm going to try to get you back on the court, back on the field, back running again, but you're going to need my help. We're going to work as a team to get you back doing it safely, hopefully in a much more healthy fashion.
Yeah, that's very cool. Now, if someone is hurting and they're like, okay, I'm going to go see a specialist instead of trying to treat myself, when should they maybe steer to a orthopedic surgeon versus someone that's not like yourself? Like you obviously said prior surgery to an area might want to go back to a surgeon.
Right. So you're still having a problem where you previously had surgery, especially in the last 1 to 2 years. I'd probably rather you meet with your surgeon first. You had a joint replacement 9 months ago. It's 50% better. It still swells. You don't have full range of motion. I want you to go back to your surgeon and make sure you guys are on the same page. An obvious thing. I mean, once again, I'm well equipped to diagnose an ACL tear. I know a lot about them. I can talk to you about the surgery. I can talk to you about the risk and the benefits and whether you should have surgery. But if you know you have an ACL tear, you're 90% sure, you're working on a team, or playing on a team, an athletic trainer is working with your team, they feel like you have an ACL tear, I have no problem with you bypassing me. Okay, I'm not going to do that surgery. Once again, you're in the ER, they told you have a displaced fracture, should you see Dr. Holmes or a non-op sports medicine doctor, or we go see straight to the surgeon? Well, we're needing surgery. That fracture's displaced. You have a hip fracture, you have an ankle fracture involving the tibia and the fibula, bypass me.
And I'm also going to remind everybody, if you watch my other interview with the orthopedic surgeon, if you've fallen and you think you've fractured something or a bone's poking out, you're going to go to the ER, you'll probably have surgery. Or if you have done anything, fallen, had an injury, and you wind up with bladder or bowel incontinence and numbness in the area of your pelvis where you would sit on a saddle, that's an emergency. You need to go straight to the emergency room.
Right.
You wouldn't want to make an appointment with a non-op
Yeah.
because he's just going to send you to the emergency room too.
Yeah. Another would be if we thought you had an infection. If you had high likelihood, once again, I can help with the diagnosis. I mean, we'll drain a lot of joints. They're swollen. We'll send a fluid off to see if there's an infection in the joint. But infections of joints and major soft tissue infections, those are a little bit outside of my wheelhouse. That's not something I see on a regular basis. So displaced fractures, infections, or problems at the site of surgery when surgery was relatively recently, especially if you have hardware. I'm not a guy that loves dealing with hardware. If you got hardware in there, you think hardware is the problem, see your friendly orthopedic surgeon. Yeah.
Now, in your opinion, how much does overall health and wellness play in terms of the conditions that you treat?
Huge. So I don't see a patient as just a condition or a body part. I look at you as the whole person. As the whole person. So we talk a lot about, what about exercise? What about diet? What about nutrition? What about mental health? What about stress in your life? Do we have some other conditions? Are we dealing with depression, anxiety? Has there been some type of recent change in your life? A divorce, a loss, a death, a job change? And so I really want to see you as a whole person, because we know that even though you may have an orthopedic condition, it's going to be impacted by all those other lifestyle issues. Weight is certainly one of them. And so we spend a good bit of time talking to patients about, are you at a healthy weight? If not, how are we going to get there? And once again, that may be a team approach. That may be working with your primary care provider. That may be working with a dietitian or nutritionist. How can I guide you on proper channels to get to where you need to get? We talk a lot about anti-inflammatory pattern of eating, which is not necessarily a weight loss plan, but we want less inflammation in our body. What's that mean? Less pain, less swelling, better function, greater ability to respond to some of our treatments, whether it be injections, physical therapy. So, and what happens if you choose those foods that we deem anti-inflammatory? You're going to eat healthier anyway. There's a good chance you probably will lose some weight.
What do you recommend? When you say an anti-inflammatory diet, what do you usually mean?
So we provide handouts for patients, and so we don't just say, hey, eat healthy. We try to be more specific, right? So they can go home with something to look at and say, oh, yes. All right, so what that often means, more fruits and vegetables, lean meats, fewer processed foods, fewer fried foods, overall, less junk food. We're not driving through fast foods. We're not eating things in a package. What can you get that's fresh? It's in your refrigerator, not your pantry. Okay. What has a good color to it, like not artificially, but a fruit or vegetable that color is natural. What about portion control, right? So even every now and then we see patients that are eating healthy, but they just don't understand the right portion. And they'll say, well, I had this, and this, and this. And I was like, well, describe to me what was the size, your portion size of that. And they'll describe it, and we're like, I think that's too much, right? So, I mean, yes, you made a healthy choice, but that was 500 calories. And perhaps, half of that would have gotten the job done. You would have derived the nutrition, the energy you needed from that food, but you didn't need that much. And so, now I'm not going to lie and say we spend half an hour talking to the patient about nutrition and healthy diet. It may be a 2, 3, 5, 10-minute conversation, but I still think that's valuable. And sometimes, once again, I need to open the door for that conversation.
Because it does impact a body's ability to rehabilitate and potentially avoid further degeneration and injury.
Yeah, a story we tell all the time, which is based on a medical study, patients that had knee pain, presumably from arthritis, lost 10% of their weight, 50% reduction in pain. So
it's huge.
Take a 200-pound male, say he's 5'10", that's probably a little overweight for him, and you said, let's get down to 180, okay? 50% reduction in knee pain. So, hey doc, my knees hurt, they're 6 out of 10. All they did was lose that weight. They didn't go exercise, they made healthy choices, better portion control, chose better foods, eliminated certain things in their diet, lost 20 pounds, their pain is not a 6 out of 10, it's a 3 out of 10.
And then they can exercise.
Right. Now I can exercise. Now I can walk more. Now I can get in the gym. Okay, I can hop on that elliptical or the stationary bike. I can be more active with my kids. All of a sudden, muscles get toner, unload the joint. Now they're 175. Now they're 170. Doc, this is the best my knees have felt in 10 years. And it didn't take a surgery. It didn't take an injection, even though I love doing injections. But it was just more of a natural approach. But it was probably slow and steady too. So it was not a quick fix. It was not a fad.
Right.
It was healthy choices. In fact, I don't like to even use the term diet.
Right.
Because diet implies something we're doing just for the short term. Healthy eating, lifestyle changes. That's probably a better way to describe
nutrition.
it.
How are you fueling your body?
Yeah, nourish the body.
Yeah.
Yeah, it's not a quick fix.
So, let's stay on that nutrition conversation. And it's not a diet because you want it to be for life.
Right.
What would you say to people in terms of when they're looking to be moderate with their diet and be healthy with their diet, but they also want to add exercise in? What do you normally recommend in terms of resources for patients? Where do you send them? Do you send them to like what the government dietary guidelines are? Or do you find that might not be healthy for everyone? I don't personally, because I feel like there are too many carbs in that. So what are you talking to people about? Obviously fruits and vegetables and lean meats, but when you say portions, what do you mean by that?
Good question. We do sometimes speak in generalities, once again, because we don't have as much time in a patient visit. We give them examples of what a right portion may be. And you always hear, for example, a right meat portion may be the size of your fist or smaller, okay? We don't need a huge plate, things overflowing off the plate, okay? We don't need to go back for seconds necessarily. Generally speaking, there are calculators we can give people a range of how many calories per day we think they need. How active they are, what gender they are, what age they are. Maybe they've counted calories in the past and they have a good idea of, hey, when I had 1,500 a day, I was losing a pound a week. If I had 1,800 a day, I didn't seem to lose weight very quickly. Dr. Weil, is a well-known, he's got a good nutritional pyramid that we hand out a lot on an anti-inflammatory pattern of eating. Once again, sometimes I do refer to the experts. So we like to develop a team of dietitians and nutritionists where I say, hey, this may not take thousands of dollars. This may be 1 or 2 consults. This may be some form of online subscription now. When I first trained, online subscriptions were not a reality.
No, there's no such thing.
But now, huge part, you don't have to leave your house to get good advice.
Right.
And so I know that's something that you work with, an organization that's offering that, where for a very reasonable amount of money, you don't have to leave your house and you can get very good dietary and nutritional advice. You can have follow-up, you can talk to a real person and kind of get that customization. So I think you were kind of referring to that. You have to customize an eating and health plan for a patient. It can't just be cookbook.
Right.
Not everybody needs the same amount of calories. I mean, we got the palate as well. I mean, I can say, you need to eat this food. And I'm like, I hate that food. I'm not going to eat it.
Terrible. I'm not eating my broccoli.
I'm 50 years old and I don't like cauliflower. And despite my wife liking it, I'm just not going to start liking it. I have a certain palate.
And
right?
everything's made out of cauliflower now.
Right, yeah. And I was kind of like, come on, can we come up with some other type of crust? You know? But there's certain vegetables that I love and I will gravitate to. And genetics have shown that, you know, it's not just people being a picky eater. Our genetics do determine how we taste food and how we smell food. And so let's customize a program for the individual. And that's not true just for eating, that's true for what we do in orthopedics. You know, this is not cookbook medicine where, oh, you got this problem, we always do this. You know, we have to take so many factors into consideration. Once again, your age, your desires, your comorbidities, you know, what are your goals, what's been tried, what's worked, what's not worked. The same would apply for eating. So that's where I like dig in, spend the time, customize something that's going to work for you.
That's awesome. Thank you. Now I've got one last question, and it was actually someone asked me, and I had an opinion, but I would love to know your opinion. Primary care providers, you go for an annual checkup. Dentist, you go once or twice a year for a checkup. How am I doing? How do you feel about musculoskeletal checkups?
Yeah, I love that. So we talk to our patients all the time. I would say in the last year or two, as I've gotten deeper in my career, I talk so much about being proactive with your musculoskeletal health, not just reactive. Reactive means I'm not seeing the doctor unless something's wrong with me and I'm really in a lot of pain, I'm heavily disabled, I just, you know, I can't do anything. So proactive over reactive healthcare, preventative medicine over just reactive crisis medicine. So don't wait to come see us only when you're in a crisis. We have created a blog. We talk about treating your arthritic knee like you would your car. Do you only take your car to the mechanic when you have a problem? Knocking, pinging, it won't start, you know, it's practically on fire, it's smoking. No, I mean, you're gonna get oil changes, fluids, tire rotation, alignment. So I love that concept. Now, I'm not gonna lie, if you have no problem, you're exercising, you have no pain, you feel great, I mean, I can see why you choose not to go to the doctor. I probably wouldn't go to the doctor if I felt fantastic. But in reality, once we get over 40, how many of us really feel fantastic all the time? We're gonna have aches and pains.
You get sleep injuries.
Sure, sleep injuries, right. What did I do? How did I wake up with that? Exactly, all I did was roll over. But it is humbling as we get older. And so I do think, look, if you have an ache or a pain, it doesn't have to be disabling. You don't have to have 8 out of 10 pain. Let's be proactive. And in our practice, we try to be very cost efficient with what we do. Look, we're not making everybody get MRIs, not everybody's getting a shot. X-rays are inexpensive. Our office visits are very reasonably priced. Even if you haven't met your deductible or your cash pay, you know, we're going to be reasonable. We're not going to break the bank. We want to be sensitive in these economic times as well as how can we take great care of you, but do so in a cost-effective fashion. But,
and ultimately help you.
Absolutely.
Hopefully avoid larger out-of-pocket costs and pain in the future.
So more regular visits sometimes prevents those big expenses or those big crises.
Yeah, that was my opinion as well. I think wellness checkups are fantastic for the musculoskeletal system.
Yeah, and I do have some patients that are doing well. They just come and say, Doc, I just wanted you to assess what does my joint look like. Hey, I need some advice on, you know, progressing into this sport or this workout program. So we do what I call some exercise prescription as well, even if overall you're doing well.
That's wonderful. Well, thank you so much for your time. I really appreciate it. I learned a lot. I know you learned a lot too.
Thanks for having me. It's awesome. Yeah.